Good evening, participants. Good evening, delegates and doctors. Thank you for joining Shield Connect. And today we are back with our series Icons in Conversation with Dr. Ritu. And today's topic is Mystery of Banning Breast Lesions. So let me introduce first Dr. Ritu ma'am. And Dr. Ritu Santwani ma'am is obstetrician and gynecologist, IVF specialist, founder and CEO of 360 Degrees Healthcare Studio. Ma'am is consultant at Inamdar Multi-Speciality Hospital in Pune. Ma'am is infertility test tube baby specialist. Ma'am has done NUHS Singapore, co-founder of MAAM and board member of SWWC. And now let me introduce our icon of the series. Today we have a special guest, Dr. Sneha Surendra Bhuyar ma'am, and ma'am is the managing director of Sukharta Hospital, Maternity, Surgical Nursing Home, Laparoscopic and Infertility Center. Ma'am has 30 years of experience. Ma'am is chairperson of Breast Committee, FOXY 2019-21, governing council member, ICOG 2021-22, chairperson of Medical Disorder Committee, AMOX 2022-24, and Suffolk member working group on breastfeeding and national expert of UNICEF. So we welcome you, ma'am, on our platform, and I hand over the session to Dr. Ritu, ma'am. Thank you, ma'am.
Yeah. Thank you, Nishan. A very warm welcome to our esteemed guest today, Dr. Sneha, madam. Madam, a very, very warm welcome. We all academic buddies all across the geography welcome you on my platform.
Thank you, Derek.
Yeah. Welcome, dear friends. Also, lot of friends have joined from the Saudi countries. Yeah, hi, Dr. Mona. I can see you. Dr. Sandrine, also I can see you from Nigeria. So, friends, as you all know, that knowledge always increases by sharing. So, knowledge sharing is the new mantra in this digital era. With this motto, I have started this series. And by the grace of the God and the grace of the blessings of the God and the elders, the series is going very well. We take every week one topic and we do the discussions with one of the stalwart. And today, none other than Dr. Sneha madam is with us. Friends, Sneha madam has created a lot of heights by working in the breast committee. So madam's lectures are very, very good and always to the practical point. So when we are discussing that which lecture we will choose for the madam, so it was great difficulty for me to decide because madam's all lectures are very, very nice. So as we all are having lot of confusions while treating this benign breast lesions, what to give, what not to give. Ma'am, this program is seen by the from young generation to the senior practitioners. So that's why I thought we take this topic because lot are having a confusion for this fibroadenoma of the breast, fibroadenosis for breast sepsis, lot of confusions. So today, madam is going to discuss with regarding all this. Friends, the program is going live simultaneously on the YouTube. So all of you, if you are having any queries, please do write in the chat box. Once the madam's talk is finished, then we can take over the question answer. Again, I'm repeating, madam is like an ocean of knowledge. So please be very attentive while listening to the madam's lecture. Yeah, ma'am, over to you, ma'am. Yeah.
Thank you so much, dear Ritu, for the invitation as well as the kind and I would say generous introduction. So with this, without much ado, I would straightway start my topic. I'm so thankful to Foxy for giving me this wider horizon to work for the common people. So as breast committee chairperson, we have really worked very hard in the field of breast. And what have we done? So we have actually tackled 3 issues, mainly the breastfeeding promotion, benign breast diseases, and awareness and early detection of breast cancer. Friends, you all know that the breast cancer and cervical cancer, these are the 2 major killers of our women. We obstetricians are saving them from the major obstetric catastrophes in their reproductive age group. And we are losing these women to these deadly cancers. And that is how we thought, that we are the ones who are privileged and we should utilize this window of opportunity to, make our women aware, to screen them at the earliest and to diagnose and treat appropriately. So as committee chairperson, we have worked at 3 levels. mainly tackling three issues: breastfeeding promotion, benign breast diseases, and awareness and early detection of breast cancer. And what have we done this? We have sensitized our Foxians. We have updated their knowledges by giving, the organizing CMEs, publishing e-newsletters, updates, and ready reckoners in the field of breast. We have organized the screening camps for the public, and of course, we have trained the paramedics. Creating awareness in common people, making them breast aware, is the most effective way we feel that our women can be saved from the deaths because of breast cancer. That is what the ultimate goal is. So, friends, you will all agree to me that the breast has always been the symbol of womanhood and ultimate fertility, and may it be the disease or the treatment per se, it evokes a fear of mutilation and loss of femininity thereby. And that's the reason all of us are here. So rather than giving a theoretical talk, as Ritu has already said, that we have practical difficulties in tackling this situation. And that's the very reason we should have the practical knowledge. So we obstetricians, by virtue of our practice, we are well versed with the problems of breastfeeding, the problems associated with breastfeeding, the engorgement, mastitis, breast abscess. Also, a few of the benign diseases like fibroadenomas, fibroadenosis, maybe galactorrhea, and problems associated with lactation suppression. All these, the women come to us. Menopausal hormone therapy, maybe the hormone therapy following breast cancer. All these women come to us for follow-up, and that's the very reason we women, we obstetricians, we gynecologists have to be well versed with all these issues. So we just discussed this first case. A 20-year-old girl, young girl, comes to you with a painless lump in the right breast, maybe since 3 months. When you examine, you find that there is a rounded, well circumscribed lump, 2 by 2 centimeter, firm in consistency, smooth surface, and it is non-tender and freely mobile. It is not adherent to the overlying skin, neither it is adherent to the underlying structure. So what is this? The diagnosis. Very clearly, you can see that it's a benign lump, well circumscribed, smooth lump, and does it really need investigations to confirm? Very rightly, all of you thought it's a fibroadenoma of breast, young girl, small in size, doesn't even need excision, but you need to have documentation. And sometimes the parental anxiety that whether this lump is going to be cancerous or will get transformed into malignancy. So we need to have the documentation. Further investigations, only ultrasonography for documentation. For young girls with dense breast, ultrasonography is the best investigation. And for this patient, reassurance and periodic follow-up is the only treatment for this. When you do ultrasonography for this patient, you find a well circumscribed, well capsulated lump, and it is echogenic, and you don't find any calcifications or so. Now, which are the fibroadenomas which necessitate excision? Fibroadenoma, actually, these are how you have to counsel the parents that fibroadenoma breast is basically a benign condition. It is nothing but the stromal and epithelial proliferation arising from the terminal duct lobular unit, and transformation to malignancy is very, very rare. Giant fibroadenomas, complex fibroadenomas, fibroadenomas persisting after 35 years of age, family history of breast cancer, these are the conditions which necessitate excision. And of course, the size of the fibroadenoma definitely matter. If it's a giant fibroadenoma or 5 loads, then it necessitates the excision. Fibroadenoma of more than 5 centimeter definitely need excision. That means it is rapidly growing. So the complex fibroadenomas, which we have already said, harboring epithelial calcifications, apocrine metaplasia, and sclerosing adenosis. These are the fibroadenomas which need excision. So this young girl she's got a fibroadenoma, which is only 2 centimeters size, doesn't need excision. You have to counsel the patient and her parents. We have to ask her to come for follow-up at periodical intervals. But definitely we have to warn her about any sudden or rapid increase in the size. If at all the patient or the parents are very, very anxious, or there is discomfort or disfigurement because of this lump, and if they are stressing on excision, then of course that is an indication for excision of this fibroadenoma. Now we come to the second case. Here we have a paravan who is delivered almost 7 months back. She's breastfeeding the baby. Now she complains of painful lump in right breast. There's no history of fever, increase in the size premenstrually. When you examine, you find that round, oval, well circumscribed, tender, mobile, but not freely mobile mass, which is cystic inconsistency. So it's a benign tumor, cystic inconsistency, mildly tender. I'm sure all of you got the diagnosis. A breastfeeding lady who's got a cystic tender lump. So most probably this is galactosile. Now, how will you manage and what is galactosile? First and foremost, our diagnosis is simple cyst, but because she's a breastfeeding lady, if at all you have any doubt, or the parents, the women or her relatives, they are worried, then you may go for ultrasonography. Here you get this cystic mass with a clear fluid, that is anechoic fluid inside. So you have to label this as simple cyst. And what is galactosile? Galactosile is nothing but a sterile collection of the milk, which is asymptomatic. If it is asymptomatic, you leave it alone. But if it is symptomatic because of the stretching and tenseness, then you may have to go for aspiration. Otherwise, galactosile is a swelling which, spontaneously regresses few days or few months after the lactation has stopped. So galactosile doesn't always necessitate the excision, but yes, antibiotics, anti-inflammatory may be necessary if the tenderness is quite significant. Now we come to the third case. A 35-year-old woman who comes to you with complaints of pain in both the breasts. This pain typically, increases before her menses and maybe few days after it subsides on its own. The lady is complaining of some lump also. So she has symptoms of pain as well as lump. But when you examine, you find both the breasts are tender and there is rice grain nodularity all over, maybe little thickening in the upper and outer quadrant. But there is no definite lump as such. So what is the diagnosis? Cyclical mastalgia, premenstrual mastalgia, fibroadenosis, fibrocystic breast disease, one and all the same. So the diagnosis is definitely a benign condition of the breast, which is cyclical. So does it need further investigation? For the diagnosis per se, we do not need any investigation. But considering this age of this woman, which is 35 years, and she is complaining of lump as well, even though clinically you do not feel any lump, it's always better to go for ultrasonography. And when you do ultrasonography, what do you see? You see multiple small cysts, which are fluid-filled cysts. If one of the cysts is larger, that is causing pain to this patient, it's better that you aspirate. Now, this aspiration will give you two things. One, relief of the pain, and secondly, the diagnosis. You can send this fluid for aspiration cytology. Now, you will all say, if it is a benign condition, why do we need to send it for cytology? Basically, previously, it was thought that fibroadenosis is totally a benign condition, but there has been a school of thought where you have the incidence of malignant transformation to at least 1.5 to 3%. And that's a very reason not to take any risk. We have to send it for, aspiration cytology. Definitely, atypical lobular or ductal hyperplasia may indicate you early malignancy or possibility of malignancy. Now, why the lady gets this fibroadenosis? This is basically a hormone dependent condition, and this is because of the estrogen excess. So that's a very reason every premenstrually you get this pain. So, what do you advise? You have two modalities of treatment. One is a non-specific or symptomatic treatment, and second is a definitive treatment. So for symptomatic relief, you have to you have to reassure the lady that it's not going to cause any type of malignancy. You have to give her hot fermentation, breast supplement, support, good breast support. And then, of course, if it is very severely painful, you may just give her either local analgesic ointment or maybe the oral NSAID. And even if it is not responding to this, then definitive management in the form of empirically over the years, though we are giving vitamin E capsules, evening primrose oil, GLA, gamma linoleic acid, and so many other things. But drugs like selective estrogen receptor modulators have transformed the treatment of this fibroadenosis or cyclical massages or meloxicam is the drug of choice. Previously, I'm sure age-old treatment was danazol or tamoxifen, which nowadays we are no more using. Now we come to the fourth case, para 1, 25-year-old who has undergone cesarean section 10 days back and who now complains of fever, painful lump in breast and severe throbbing pain in the left breast. On examination, the patient is febrile, she's got tachycardia. When you examine her, both the breasts are engorged and tender, but right breast has no lump and left breast is having a tense, tender, hot, fluctuant swelling of 6 by 6 centimeter. So, para 1 cesarean section done, breastfeeding mother with symptoms of infection. So this is basically the breast abscess you all can see here. So how do you manage this case? This is basically a complication of the breast feeding. And how do you treat this? First and foremost, our aim should be to continue breastfeeding because this has happened because the lady has not breastfed the baby properly. So previously, the age-old treatment was incision and drainage, but it is very, very painful and messy treatment, I would say. Incision and drainage leads to, very painful dressings and compressive dressings daily, and the patient has to almost stop her feeding her baby. But nowadays, we have what is called as needle aspiration, where you go for aspiration of the breast abscess, and maybe if it's a small swelling, definitely you may do it with a single sitting. But such a large abscess, you may have to go for multiple aspirations. So if it's a deep-seated swelling, you may have to go for ultrasound-guided aspiration of this breast abscess. So how do you do this? You have to take a very wide bore needle, almost 16 gauge, and you have to aspirate it with the help of syringe. And you have to break the loculi as well so that they don't refill it again. How do you compare this? This is a Cochrane review saying that both these methods, they have had larger studies, almost 6 studies, 325 women in each study, and they have come to the conclusion that both these methods, that is incision and drainage and aspiration, are needle aspiration. They are equally effective, safe for both the mother as well as the baby, but because here in needle aspiration, you don't need to give the patient anesthesia. So she doesn't need to undergo any surgery. So there is no pain. And of course, there is no wound. So the mother is, able to continue breastfeeding to her baby. And that's a very reason needle aspiration is the most effective way, along with, of course, antibiotics, anti-inflammatory, hot fermentation, and the most effective method is continuation of breastfeeding with good effective latch, complete unrestricted feeding every 1.5 hourly. That is what is going to solve her problem. Now we come to the fifth case where you have 35-year-old woman who comes with a swelling in the left breast. It's not painful and when so how do you evaluate? Suppose she has a lump and it is painless. So just to know how do you evaluate this. So for any lump in the breast, you have what is called as triple algorithm. That is history taking, which is most important, right from her family history, medical history, age, parity, including her, menstrual history, early menarche, late menopause. So many things in the history, they point towards your diagnosis. Clinical examination. When you say how do you examine the swelling, whether it is rounded, well circumscribed, whether it has got a capsule, it is freely mobile or no, whether there are associated axillary lymph nodes or no. So all these things will, definitely guide you towards your diagnosis. So history taking and clinical examination. Then next is imaging, whether young woman less than 40 years, we have to go for ultrasonography. More than 40 years, when the breasts are not so dense, and that is a preferred method for screening, that is mammography. And then finally, tissue diagnosis. So if it's a cystic mass, then you have to go for aspiration cytology. If it's a solid mass, then you have to go for true cut or core biopsy. So that is what is the triple algorithm. So for this young lady, 35-year and a mass which is painless, when you examine, you find that it's a vague, irregular, hard, painful lump. And yes, so when you say vague, irregular mass, painless lump, sorry. So possibility of malignancy should always come to your mind. And then the diagnosis, of course, sonomammography, which is much complementary to the diagnosis. If it doesn't point, sono and mammo both are inconclusive, then you have to go for MRI. And then, of course, finally, the true cut or core biopsy should point to the diagnosis. Basically, we want our women to be breast aware, and that's a very reason I would suggest that every gynecologist should make it a habit to take an opportunity to examine these women. How do you do that? So you do inspection and palpation. How do you teach these women? You have to teach these women that whatever examination I'm doing now, you have to do it at home. When she should do that every monthly during the postmenstrual phase. Now, the woman has to stand in front of the mirror while having her bath. She has to expose herself properly, and she has to watch for any abnormalities, if at all she has. So whether there are any abnormalities like any difference in the size of the breast, whether any lumps or dimples, whether any discoloration, scaling, any wound, superficial ulceration, and of course a nipple retraction. So sometimes you can even see the nipple discharge. So if the lady can see any of these abnormality, that is on inspection. After that, she has to lie down, or maybe in standing position itself, she has to examine both her breasts, which she can do with the help of her own hands. Like right hand she can use for left breast and left hand for the right breast. That is how she can examine herself. This is what the picture is showing. So on palpation, she has to palpate it right from with the palmar aspect of her middle three fingers. With she has to press it firmly hard on her breast from upside down, side to side, concentric or radial, and she has to look for any lump. And if at all she finds any abnormality, she has to report to her doctor and get investigated. So basically, when we clinicians do this same examination, then we label it without using any gadget, then we label it as clinical examination. And when we ask the patient to do it for herself, then we label it as self-breast examination. So both these examinations are very, very useful and very effective means of screening as far as breast cancer is concerned. Of course, for younger women with dense breast, ultrasonography is the preferred imaging method. Mammography, I would just make you all aware that mammography is the gold standard for screening of breast cancer. And as gynecologists, we must always know when to start. So for an average risk woman, we should always start it after 40 years of age, because there are so many organizations which unanimously accept or agree that for an average risk woman, there's no need for screening before 40 years because the incidence of cancer is very, very low before 40 years. So 40 to 44 years, you offer the woman annual mammography, but 45 to 54, you have to make it mandatory annual screening. If you don't find any abnormality in during this period, then you can taper it down to every 2 yearly after 55 years till 70 years. So 55 to 70 years, you can taper it down. And of course, then you can stop when the life expectancy is less than 10 years. So these are what some imaging pictures of mammography. So we would not go into the details because we have to restrict ourselves to the benign breast diseases. MRI, just to complete the presentation, and this is the tissue diagnosis, various types of biopsies, what I have already discussed. These are the various organizations where they are, advising us that for an average risk woman, there is no need for screening before 40 years of age. And this is the American Cancer Society guideline, which has actually, which is the most popular and most accepted. But for a low resource country like India, it is not affordable and not cost efficacious for us. And that's a very reason we have come to the conclusion. I think there are few more organizations which have come to the conclusion that maybe every 2 to 3 yearly mammography should help and should be cost efficacious for a country like India. So I would urge all of you that as obstetrician and gynecologist, we are the privileged one, and we should utilize this window of opportunity to examine each and every woman, because women are very comfortable with us gynecologists, and they come to us for whatever their problems may not be only the reproductive organ, but it may be anything. They believe in you because for so many years of their lives you have helped them. So making use of this opportunity, we have to examine her. If there is any abnormality, we subject her to investigations and help her diagnosing at the earliest. If no abnormality, we can advise her or train her for self-examination and warn her about the adverse signs so that she can report to you at the earliest. And of course, we may not be able to prevent the malignancy, but we can diagnose at the early stage, which is completely curable. So early detection not only saves lives, but also saves the breast of the woman. So with this, I humbly urge all of you that myself, Dr. Sneha Buyar, I have been working for Foxy since last almost now 22 years. I'm a practicing obstetrician since last 30 years, and I have worked as obstetrician and now also in the field of breast to a large extent, and with all my efforts, I'm going ahead with Foxy Vice President from West Zone for the upcoming elections. And I request all of you to support my candidature and vote for me for the upcoming election. Thank you so much, organizers. Thank you, Dr. Ritu, for giving me this opportunity to interact with all of you. And thank you so much for the patient listening. Thank you so much.
Thank you, madam. Thank you so much in advance from our side. Congratulations to you. So, ma'am, we have received a lot of appreciation, ma'am, and I have got a bombardment of the questions in the YouTube. So, with your permission, can I start taking one by one?
Sure.
Yeah, ma'am, there is first question from Dr. Sinha. She has joined from Motihari, Bihar. Question is, ma'am, you have elaborated very nicely. Now, one question is that how to distinguish the benign disease from the malignant one? I think madam is taking, she must have joined late. Yeah.
So actually, this point we have covered it in a very systematic manner, that any lump in the breast, we have to follow what is called as triple algorithm. That is 3 things. One is history and clinical examination. Second is imaging, and third is tissue biopsy. So whenever you have this lump, right from the history, I have said the age, menstrual history, early menarche, late menopause, And of course, the parity use of OC pills, hormonal menopause, hormonal therapy, whatever, and the family history and medical history. So this is history and clinical examination. How do you find the lump? Whether it is a smooth surface, rounded, not adherent to anything, and it is freely mobile. That is two. And thirdly, the imaging. As per the age of the patient, less than 40 you go for ultrasonography, more than 40 you prefer mammography, and last not the least, that is the tissue diagnosis for confirmation, that is biopsy, the true cut biopsy for solid lesion.
Yeah,
I hope Dr. Sinha, you have received the satisfactory answer.
Yes, we will wait her reply. Ma'am, there is another question from Dr. Bashir. He has joined from Somalia. Dr. Bashir, thank you for joining. He usually always joins our webinar. That's why we keep the webinar, ma'am, such. So late timing. Ma'am, his question, very excellent presentation. One query, that how one can differentiate the benign breast diseases with the inflammatory breast conditions.
Yes. So first and foremost, even the inflammatory, benign breast disease will be, we will categorize it as congenital, traumatic, inflammatory, and miscellaneous. So even the inflammatory lesion is one of the kind of the benign lesion, I would say. So inflammation naturally has its own characteristics. Maybe if at all, it may be associated with fever. It may be associated with the local signs of inflammation. That is, as we have been learning right from our UG days, the color, the dolor, and the tumor. So you have tumor, that is the lump, and then you have dolor, that is pain, and red, hot, tender area. That is how we differentiate it from the other benign lesions, I would say.
Yeah, thank you so much, ma'am. Friends, meanwhile, if you are having any here questions, please do write in the chat box. Meanwhile, we are taking the other questions what we received by other social platforms. Ma'am, there is a lot of appreciation by Dr. Rehana. She has joined from Dhaka, Bangladesh. Her query is, in a 35-year-old patient with the BRCA mutation, breast sonography is carried out for a newly discovered palpable mass and fibroadenoma is suspected. Ma'am, shall I repeat?
No, it's okay. BRCA positive, she said.
BRCA1 mutation, yeah. And the fibroadenoma is suspected. What should be the next line of treatment?
BRCA mutation positive, that itself is a separate chapter. Whether the patient, whether the patient has any lump or doesn't have any lump. Once she is high risk, that is whether she has the very fact that she has got her BRCA mutation tested, that means she must be having some high risk factors, that is family history of breast cancer. It is understood. So family history of breast cancer puts her at a category of high risk woman, not average risk. So breast cancer is the only cancer, I would say, where you have only two categories, because every lady has 1 in 8 chance for having breast cancer in her lifetime. So this lady has high risk, she is high risk, and that's the reason she has done her BRCA mutation testing. So once she is BRCA mutation positive, in fact, BRCA mutation positive has its own protocol to be followed. Now she comes in the category of high risk. So for her, right from early age, the 20 years of age, she has to get her clinical breast examination annually, and she has to get her mammography and MRI done from the age of 30 years every 6 monthly. If at all with this, if there is no abnormality, even then she has to be examined, she has to be explained that because she's BRCA1 mutation positive, for her, the risk of breast malignancy is very high. And not only breast malignancy, but the ovarian malignancy as well. So even if she doesn't have any lesion in the breast, she still offered the, some kind of prophylactic. Either you have two ways. Either you just go for surveillance and monitoring and every 6 monthly or annually MRI and mammography, or you go for, either prophylactic mastectomy or prophylactic oophorectomy. Because if you consider the BRCA1 and BRCA2 mutations, and if you look at the incidence of malignancy development, that is very high. So you can offer her both the things. Now for this lady we will talk, because she already has fibroadenoma. If you remember, when I discussed the case of fibroadenoma, I had specifically said that even if she is a young girl, and even if the fibroadenoma is very small, that is 2 by 2 centimeter, now, because she is high risk, it's better that we excise the fibroadenoma and send it for histopathology. So this is a case where you have to get your diagnosis confirmed that it is benign lesion.
Thank you so much, ma'am. Yeah. Ma'am, there is one more question. Rest are most of the similar questions. This is one question the doctor is insisting. Yeah, the doctor has joined Dr. Jadhav from Satara. Not the full name. It's mentioned this much only. What are the most important therapeutic measures in a patient with incipient puerperal mastitis?
Incipient.
And yeah.
Puerperal mastitis.
Mastitis. Yeah.
Okay. So for mastitis basically is inflammation of the breast, which we say, or we take it as commonly as the complication of the breastfeeding, during breastfeeding. So what are the reasons for this? We have to analyze what are the reasons, then we come to the proper treatment. So lack of initiation at the earliest, that is one. Secondly, improper attachment. And thirdly, incomplete or delayed feeding of the baby. So that leads to engorgement and that leads to mastitis. So basically, initiation is delayed. That initiation should be at the earliest. What do we mean by this? The government of India says that initiation should be as early as possible, and for this they are training even the government medical officers and whatever the paramedics and health workers. They are training the paramedics to deliver the or the nursing staff to deliver the baby on mother's abdomen, what is called as mother's absolute affection. That is the MA initiative of the government of India. So to deliver the baby on mother's abdomen, let the baby crawl towards mother's breast on its own and let the baby start breastfeeding, what is called as breast crawl. So earliest initiation should be this early, even before cutting the cord. That is one. But for us, commonly practicing obstetrician, it should be at the earliest, but preferably before 1 hour. That is why we label it as golden hour of breastfeeding. Okay, so that is one. Secondly, it shouldn't be a scheduled feeding. It should be demand feeding as early as possible and as frequently as possible. Maybe for first few days to weeks, it may be just maybe half an hourly to 1 hourly also. And the feeding should be with good effective latch. Now, what do we mean by this good effective latch or good attachment? That means the baby's mouth should have the nipple, not only the nipple like this, but the nipple and the areola part around. The nipple and the areola around the complete dark cervical, at least the baby's gum should overlie the areola. So good effective latch means the baby should have nipple and the areola inside the mouth, and then that's how the baby should suck. So that is good effective latch, so that the pumping becomes very effective. And even the what do we call it as oxytocin reflex, because the baby sucks, there is transmission of this reflex to our posterior pituitary, and there is release of the oxytocin, which is responsible for the milk letdown. So if this milk letdown is effective, there is no engorgement, and of course there is no mastitis. So how do you treat this? Definitely you improve on the latch, good effective complete unrestricted feeding, and then for symptomatic relief you give hot fomentation and good breast support.
Yeah. Thank you, ma'am. Ma'am, there are a lot of questions are coming, so I'm taking one more question
Yeah,
here
yeah,
in the
sure.
chat box.
Chat box,
Uh,
yes, ma'am. There is
yeah, yeah.
a question
There's
by
one question.
R3.
Question by
Patient
who?
is unmarried, having multiple
Please take the
large
name of
recurrent.
the doctor also, Nishan. Doctor का नाम बता दीजिए. हाँ. Who is?
R3 iPad.
अच्छा,
R-
okay.
R3 ही होगा. So she is asking the patient
Yeah.
is unmarried, multiple large recurrent fibroadenoma.
Hmm.
How to treat it?
Yeah, so these are actually what is called as phyllodes tumor. Multiple large fibroadenomas that we label it as either giant fibroadenomas or phyllodes. So basically, she has very nicely said it's a recurrent one. So fibroadenomas, multiple large fibroadenoma, we label it as giant fibroadenoma, but there are certain types of this fibroadenoma which is called as phyllodes. So in these phyllodes, you have either the benign phyllodes or the malignant phyllodes. Looks like young lady and the rounded and well circumscribed, very typical of fibroadenomas. Whenever you have this fibroadenoma, the phyllodes tumor, first and foremost, you have to conceal the patient and relatives that these are basically, when you confirm the diagnosis, these are basically the benign tumors. Whenever, because this is very large, maybe you have to remove it, but then these are the very notorious tumor which are going to recur again and again. And in this situation, the patient can blame you, maybe even sometimes sue you. So that's a very reason whenever you are taking the consent of the patient, you have to take a informed written consent saying that this is what is called as phyllodes and this may recur. So with good explanation, you have to treat this patient, remove it. But there are certain drugs now available. One is SCRMs, Cevista or meloxifene. These are the drugs, they are definitely very helpful in such kinds of patients. Yeah.
Yeah. Thank you. Thank you so much, ma'am. Ma'am, there is one more question from Dr. Arpana Agarwal. Yeah, hi, Dr. Arpana. She's writing, ma'am, Dr. Atri is writing regarding the dose of
I will, yeah, same one, no? What is the
Yeah.
dose of serum? Yeah,
Yeah.
so SCRMs, what is available, or meloxifene, or the various names, I will not say the brand name, but or meloxifene. So it is 30 milligram
Yeah.
twice a week, and
Yeah.
that is at least 3 to 6 months.
Yeah.
30 milligram twice a week, at least 3 to 6 months.
Ma'am, in some, if the patient is of the more body weight, in some patients we are giving 30 mg alternate day also. What's
Yes,
your?
definitely.
Yeah.
Yes,
Yeah.
it will definitely help better because
Yeah.
alternate day is the best treatment. But yes, we have got good results with every third or fourth day. So it's twice a week. Yeah.
Okay. Okay. Yeah. Thank you, ma'am. Ma'am, there is one question from Dr. Arpana Agarwal. Yeah, hi, Dr. Arpana. Any role of OCPs to prevent prophylactic oophorectomy in BRCA1 mutation positive? Abhi, next lecture, I will request ma'am for the breast cancer. So we
Yes.
will cover in that. Because
Definitely.
it is, yeah. So with this, I think most of the questions are same.
Mhm.
So yeah. So with this, we will wind off. Before we wind off, ma'am, we all see you as our inspirational leader. We all want to be like a ma'am. So, ma'am, before we wind off, we
Okay.
want some take-home message for the young budding gynecologist from your side.
Regarding the subject or in general?
Ma'am, regarding, because we see you as our role model. So what we can also do to become a madam-like personality and madam-like leader. Yeah.
First of all, thank you so much, Dr. Ritu, for all the appreciation. And I'm really humbled and blessed. I'm feeling with all the stalwarts also. So many doctors joined here. I would just say, see, I'm not somebody great. I'm just a common human being, I would say. Yes, definitely. What my experience is that you have to do your work with passion, dedication, hard work, and sincerity. That is what I have been doing over the years. And I'm sure I'm just a common obstetrician gynecologist like majority of you. And after 25 years of my dedicated service, I started devoting wholeheartedly to the organization. As an obstetrician, I have been practicing as high risk obstetric practitioner. But when my intention is, always do whatever you want to do with wholehearted, whole heart and passion. So even when I'm practicing as a high risk obstetrician, when I decided to be the chairperson of Foxy for breast committee, I just thought that I should work for community. Whatever I owe so much to the society, and with this field of breast also, breastfeeding, breast cancer, benign breast diseases, at all three levels, sensitizing the Foxians, training the paramedics, making awareness in the general public. So all of this, at all levels, I have tried my best. And I think your good work and goodwill takes you to the next level. So that's what I believe. Thank you so much.
Yeah.
Believe in yourself, believe in God, and believe in law and protocols. Thank you so much.
Thank you, ma'am. Thank you so much. Ma'am, there's one last question from Dr. Atri. She is requested to take. What is the definite treatment for fibroadenosis?
Fibroadenosis.
Yeah.
Yeah, that we have already discussed. I think she joined late. Yeah. So I have already said that fibroadenosis is basically a hormone dependent condition. And because it is estrogen dependent, first and foremost, your aim should be to curtail the exogenous estrogen. So if at all you are taking OC pills or combined hormonal contraceptives, you have to stop taking the exogenous estrogen, and then you have non-specific and specific management. So your diet should be, should not have extra added sugar. Your diet should be rich in fibers, and your lots of what you say, caffeinated drink you should avoid. So healthy diet and healthy physical activity, healthy living should be preferred. And of course, as far as the medication is concerned, we have said that empirical medications, vitamin E and gamma linolic acid and so many other things, evening primrose oil, but ormeloxifene seems to be the definite management. So I think, hope Dr. Atri, you have got the satisfactory answer. Thank
Dr.
you so
Atri,
much.
you are from which place? Dr. Atri, you are from which place? So now with this, we are winding up for the today's session. Friends, I have posted my mobile number in the chat box. Those want to be a part of the academic group, please do drop me a message with your full name and your workplace. So I will happy to add you all in the academic group. So madam, thanks a lot from all our side, and thanks for gracing this platform. And thank you so much, dear Nishant and Sahiti, my co-buddies, who are always there to help me and assist me. Yeah, thank you, Sahiti. And thank you, Nishant. Yeah.
Thank you so much, Dr. Ritu, and thank you all the delegates, and thank you, Nishant and Sahiti Priya. Thank you so much. Pleasure to be here.
Yeah. Thank you, ma'am. So with this, we are.
She's Dr. Beena from Valsad.
Dr. Beena from Valsad.
Madam, are you Dr. Beena Nayak?
Yes, Madam? Yes. Now I got it. Madam, yeah, Dr. Beena.
So, okay, friends, we are winding up for today. Now, for the coming sessions, which topic you want to discuss, let me know so we can finalize.
She's writing that I can't unmute.
Anyhow, we are winding up now.
Yeah. Next time. Yeah, sure.
Next time. Otherwise, ma'am, you have to sit here till 11. Questions won't end.
I know. Thank you so much.